So I thought we'd just go a little bit through pre-procedural preparation, a few of the most complex lesions that generate the most work for us, a bit by ablation by lesion and some of the evidence by lesion, and a few tips that I've found useful over the years for ablation in the most complex structural lesions.
There is some echo about the sound. I don't know
Dr.
why.
Ashrafi, can you use only one device for presentation and mute the other one?
Is that better? That sounds better for me.
There is some beeping from, you are using two devices, so
right,
one of them is making interference.
The table on screen at the minute is taken from a paper by Paul Kyrie and Consensus Guidelines back in 2014, which I think for me is the starting point in all complex congenital ablation, to think about my lesion. And if I can think about my lesion and the operation the patient has had, I can then predict what my arrhythmia burden is going to be, how likely it is. And so I can start to, if I see people in clinic, prepare them things to be aware of and try to prepare them for the likelihood of that arrhythmia and the likelihood of my success in treating it. So as you would imagine is obvious, the more complex your structural lesion, the more likely you are to get some form of an arrhythmia. So as you come down the
please, excuse me.
The table, the transpositions and the single ventricle pathologies give you by far the most amount of work. So, I think for the electrophysiologist, if you're taking someone to the cath lab and you're preparing yourself for the more complex structural abnormalities, as well as understanding the background lesion, you have to have understood what the surgical treatment has been. Because if you can't understand the surgical treatment and what's been done, you'll find it very difficult to interpret the scar pattern when you take them to the lab. And a lot of these scar patterns are easily predictable, dependent on the surgical operation. So what you can see here is transposition of the great arteries with VSD and an arterial switch and VSD closure. So on that basis, I could then predict what I might see in the EP lab, VT from VSD patch, VT from coronary abnormalities during the arterial switch. So I think it's very important as the electrophysiologist treating them that you have to understand what the surgeons have done. And sometimes going back through the operation notes or talking to your local surgeons can really be invaluable. They may tell you an awful lot. Frequently they will tell you if they've closed the coronary sinus, if they've left a hole somewhere, if they did a more complex atriotomy. And especially if you work with paediatric patients, you do have the opportunity to discuss with them. Say, look, if you're doing this operation in the future, can you do this for me? It'll make my EP job in the long term that much easier. So, coming more towards the day of the procedure, things to remember. You have to have access to the site you want to ablate, and have you considered, what issues you might have? Does this person have left atrial isomerism? Does then the right femoral vein join to a left-sided IVC, which joins to a left-sided SVC, which may rejoin to the right SVC, but may join to the CS? And so you have to then think, well, that's a long way for my catheters to go from the leg. Am I really going to be able to get far enough round? Will I have enough support? If my target is, an outflow tract ectopic, that's a lot of catheter torque and you will struggle. So should you be going from the neck or from the subclavian? The other things from an access perspective is lots of these people will have had 2, 3, 4, 5 operations in childhood. They may have had ECMO, they may have had femoral cannula, they may have had, sheaths in for percutaneous interventions. And you may start to run out of access in general for these people. And so you do have to sometimes think slightly more laterally in terms of access points. And some of my colleagues will do access from the hepatic vein if femoral veins and the jugular veins are blocked. The next thing you have to think about is your patient preparation. And I guess this is dependent on your healthcare system and what you have access to. Do you have access to general anaesthetic support for your case? Is trying to do a long, complex Fontan under sedation going to be difficult due to patient tolerance? Have they had a lot of psychological trauma from multiple childhood operations and interventions? Depending on what you have access to and how much general anaesthetic support, sometimes general anaesthetic can just make your ablation treatment much, much easier just because your patient toleration isn't an issue. But if you're going to do that, especially for the most complex cohorts, you need to think about the airway, their hemodynamic stability in sinus rhythm, their hemodynamic stability in arrhythmia. We know that a lot of our more complex Fontans, even in a slow atrial tachy, will become hemodynamically unstable. And so can you do things to prep before? Can you try some inotropes? Can you treat pulmonary hypertension? Can you do a few things to make your electrical procedure easier from the hemodynamic perspective? So I guess lots of this depends on, to an extent, where you are and what your spectrum of congenital heart disease is. But I just thought I would talk through the four groups that give us the most work here in the UK. So the first one is Epsteins, which I think is quite a nice lesion to think about from a structural perspective. So if you look at the picture on the right, essentially this just begins with failed delamination of the tricuspid valve leaflet from the septum, giving you an atrialized right ventricle, an abnormal tricuspid valve, a lot of TR and a small ventricular portion. And there's a very wide spectrum of how much atrialization there is, and that will define how well or badly the patient does from a hemodynamic perspective. So if you have an abnormal tricuspid valve and atrialization of your right ventricle, you're going to seriously affect your right atrial size and your conduction tissue development. So that brings us into what's normally the biggest problem in childhood for these guys is accessory pathways. And I guess this, for me, we would see this in about 25 to 30% of patients. And it's almost all right-sided, posterior posteroseptal. Most commonly, you'd see more than one pathway, and it can be quite a wide spectrum of pathway fibers. And dependent on this septal leaflet of the tricuspid valve, getting to these things can be a real challenge. If your septal leaflet is very, very deformed and covering a lot of these areas, getting to the pathway can be tricky. In terms of acute success rates have remained fixed over the years. There have been several studies, and the most recent one from Boston Children's still shows the acute success rates are about 90%. And as 3D mapping and ablation technology has got better and better, this has improved, and the recurrence rates for accessory pathways in Epsteins now are about 19-20%, having been nearly 2/3 many years ago. And I think certainly from my perspective, although I would do most of my accessory pathways in structurally normal hearts and maybe simpler congenital heart disease with just, catheters, the Epsteins cohort is one I would, if I have the availability, I would try and do with a mapping system. And you can see some nice pictures here. I think it's from a Japanese group where you can show the accessory pathway and the early few signals quite nicely on the Carto map. And I think the Carto map gives you a feel for just how abnormally, placed everything is. Got a nice overlay picture here. And I think certainly I've struggled in the past, to identify everything just via, standard catheters alone. I guess what I would see more commonly in the adult cohort is the intraatrial reentrant tachycardia or a flutter. And this would most commonly be a CTI-dependent mechanism from the atrialized tricuspid valve back to the IVC as normal. And this can often be a very long line depending on how big that right atrium is. And we've certainly done 10, 11 centimetre long lines in some patients who've been unoperated on. You do see in other people in re-entrant tachycardia, especially if they've had multiple operations and atriotomies. And I put up an ECG from one of my patients who was ablated in one of the centres in London twice and then has been up with us 3 times. And he'd had an accessory pathway ablation in London. He'd had a CTI ablation in London. I'd done a focal atrial tachycardia, and I'd done a intercable line from the SVC down to the IVC. And then he represented with this tachycardia, which I have to say I didn't really get much of a clue from the ECG as to what I was going to find, but on the day turned out to be CTI dependent again. And I think what's important here is what's illustrated by the Mayo group, in which I say to all of the most complex structural cohort that recurrence rates are high. And if we can buy time, buy some improvement, we will, but the patients should prepare themselves to come back and that they are likely to get further arrhythmias. And similarly in this gent, acute success wasn't difficult, but durable success is. So from my perspective, I think steerable sheath support is invaluable in these patients, especially the more and more tricuspid regurgitation they have. I think you're talking about very thick scar tissue. You're ablating at high powers, so you need to give yourself the best chance of good contact and good lesion generation. I think a steerable sheath here really does help you. And we would always do this at high power with an irrigated catheter. Personally, if the mapping system is there, I would take it always in the Epsteins cohort for anything intratrial or any flutter, even if it's a first-time flutter and they've been unoperated on. What you can see here is from the gent to the ECG I just showed you, is that he's had previously a tricuspid valve repair, followed by a surgical tricuspid valve, and now he's had a percutaneous tricuspid valve-in-valve procedure. And between these 3 procedures, the team have covered his coronary sinus completely. So a lack of a stable reference can be a real issue. I would tend here to put the CS catheter in a halo-type pattern in the right atrium. But I think one of the options you may have, especially now with the precision system from Abbott, is you don't necessarily need a stable reference and that you can just use the omnidirectional catheter to make your map with. And in this gent, I haven't got the picture of the ablation catheter, but he had CTI-dependent mechanism, and as you can see, this sheer amount of metal and prosthetic valve material makes trying to take out the residual CTI quite difficult. What I tried to do initially was retroflex from the RV side back under the prosthetic valve tissue to see if I could get the remnants of the annular signals, but that is difficult, and getting tangled in the valve can occur. And so sometimes you may need to do a wide area of ablation on the atrial side just to help yourself. And bipolar ablation may be an option here. Oh, jeez. Sorry. Next is Tetralogy of Follow. And I've just put up a few pictures there of the structure to remind us. And I think if you look at Bob Anderson's slides on the right, it's quite nice at illustrating that Tetralogy of Follow at its core is just caused by movement of the outlet septum. And this movement of the outlet septum pushes, giving you the infundibular stenosis, giving you aortic override, and creating the VSD, and thus the RVH. didn't think it was that interesting to talk through atrial ablation in Tetralogy of Follow, but what I find the most challenging work in them, which is VT ablation. So I've just reproduced here Katja Zeppenfeld's, I think essentially reference paper with the critical isthmuses in Tetralogy of Follow, which, as I said at the start, are largely based on the surgical intervention. And so what you can see are the key isthmus points here, from the pulmonary valve to the tricuspid annulus and around the RVOT incision point and VSD patch. So although there are at least 4 isthmuses that are common, there is now, we would find in the modern era, essentially one most important isthmus that drives most of the VT we see. So I've just put up a map using the rhythmia system for one of my gents who presented in sustained VT. And essentially what you can see, similar to Zeppenfeld's critical isthmuses, here you have the critical slow isthmus posterior from the pulmonary valve annulus and a circular slow VT across that. And if I show you the ablation, what you can see is that just by starting to ablate in this slow zone, pretty much with my first lesion, we get termination of the VT, and then with consolidation through this critical posterior slow isthmus, he was then non-inducible and has remained VT free for over 2 years. So I think in terms of the long term for these people, Zeppenfeld and her group would suggest that if you can block these critical isthmuses and prove block and be able to terminate the clinical VT in the lab, in the presence of a more modern a more modern tetralogy operation, that these people don't need ICD therapy. I guess in my region we deal with a lot more older style VT, so we haven't felt that confident to go that far, but certainly I think if you can block these isthmuses, you have a very good chance of remaining VT free in the long term. And I think a 3D mapping system here really does help. Although I guess you probably could just look for the fractionated signals here posteriorly and do your lines based on that. So moving on to the third of my more important groups in complex congenital ablation is the transposition treated by mustard, which thankfully are becoming a thing of the past here with the arterial switch operation. But I still have quite a large cohort in this region. And in these guys, by far and away the most common arrhythmia is an isthmus flutter from the original cavo-tricuspid isthmus, but complicated by the posterior baffle. So it would start as normal from your tricuspid valve, but this baffle here causes a degree of complication for you. So you do need to just do a standard CTI line, and your options are to come retrograde aortic. So if you come retrograde through the aorta and then tight turn back through the tricuspid valve, and then you'll probably be able to ablate the portion from the tricuspid valve here to the baffle, and then you'll need to also then come from the femoral vein and do the final portion. There really isn't really good data on, outcomes or ablation techniques in this cohort, and again, recurrence rates for these would be higher. Again, personally, I would always do with a mapping system, because I think in a more complex hemodynamic cohort, you want to be as quick as you can, especially, if you're doing it under general anaesthetic. And I think, still I have colleagues in other centres who believe that they can, completely treat the arrhythmia by only treating one end of the baffle, and I think that's impossible. You will always have to get to both ends. So I think the retrograde aortic approach, a bidirectional catheter, is very helpful because it'll just give you an extra option as you try and make that tight turn from the RV back up through the valve. Personally, I tend to avoid the retroaortic route due to the risk of vascular injury, and I would always tend to come through a TransBaffle puncture. Personally, I always use a radiofrequency needle because I think when you're trying to get through thick Gore-Tex or Dacron patches, the standard Brock needles do struggle. The extra sharp can help you, but often it does require quite long and persistent pressure before you eventually sort of harpoon through. Cook used to make the Endress needle, which was much stiffer and much easier to puncture with, but sadly that's gone out of manufacturing, and so largely me and several of the other UK electrophysiologists for the baffle puncture would just use the RF system. And I thought I would just illustrate that there are options if your femoral veins are blocked. The puncture from the jugular vein through the baffle is one of the easiest and straightest punctures there is in all of EP. All you need to do is push the sheath down through the SVC, and essentially the first place you will pop up in the residual right atrium will be an absolutely perfect angle to puncture through the baffle. And so if you're struggling from the leg, this is a very nice bailout strategy. And just on the right, I thought I would show one of the more interesting ones. This is from a gentleman with CCTGA who's had a double switch procedure and cardio with his heart rotated more medially. And I tried to come retroaortic, but the catheter course was in a very difficult orientation. So we came from the left internal jugular. You can see a coronary sinus from the left IVC through the hemiazygous continuation and back into a left SVC. So from the left jugular, I've again perforated through the baffle back into the atrial mass, which I don't think I would have got into the atrial mass in any other way. And then just to our final cohort, which I think probably are a good 30% of all my congenital EP work, is the Fontan Cohort. So I'll just put up the three common Fontan operations. And there are variations of these, and each surgeon does have his own personal variation of them, but these are the three general. Well, first we have the atriopulmonary connection described by Fontan, which again largely out of use now and has been for about 20 years. Then the next iteration by Marc de Laval, the lateral tunnel, utilising part of the native RA tissue and a patch baffle to create your lateral tunnel, and then a Glenn shunt from the SVC. And now what is the most common iteration we have now, which is the extracardiac TCPC, where you have a separate Gore-Tex conduit taken off the right atrial wall and the Glenn shunt. So I think it's important that when you're talking about ablation in the Fontan cohort, you have an idea for yourself and the patient as to what to expect. What you can see here from these two graphs is that if you have a modified AP Fontan, atrial arrhythmias are obligatory as they get older. There is no one who hasn't had them. And I think there is almost no one in our service who hasn't required multiple ablations. As you come up the more modern surgical approach, you can see that largely the extracardiac conduits do better and better. And I think this is largely due to right atrial stretch. Once you've eliminated this by using the extracardiac tunnel, your risk drops significantly. So understanding your cohort gives you a bit of information to consent your patient with. So if you look in the atriopulmonary group, it's almost always a macro-reentrant atrial arrhythmia. You can almost always get it in the systemic venous atrium. And the number of tachys that you would see in most people would be at least 2. And certainly my experience is I virtually never get less than 3 in these people when they come for their procedures. And once we can get a success rate on the day for the clinical one of about 80%, I think the recurrence rate is at a minimum 30-40% over the next couple of years. And most people understand that they will need to come back for multiple procedures. In the lateral tunnel, again, macro-reentrant, you're less likely here to be able to get all of the tachycardias within the tunnel, because the most common isthmus, if you like, is from the original AV valve back down to the IVC, almost like a CTI flutter. So whilst you'll be able to get the IVC portion and a portion of the right atrial right atrial portion of the arrhythmia, getting to the AV valve portion is difficult. And so often you will either need to come retro-aortic, or certainly my preference is to do a conduit puncture and then take out the AV valve portion. And for the extracardiac cohort, similar to the lateral tunnel, you will almost always need to get to the AV valve. I guess in this group you're always going to need to do a conduit puncture or come retro-aortic, because you'll have virtually no access to any electrical tissue within the extracardiac conduit. But success rates are good, and certainly acute success rates, I would agree, are in the 75-80% mark, especially as the technologies have got better. I just thought I'd show a few pictures of maps from the atriopulmonary group, just to give you an idea of how scarred some of these atrial masses can be and how big some of them are. I mean, certainly we've had people who've had 500, 600 mil atriums with very slowed conduction and multiple atrial arrhythmias within this. And you can see in the voltage in this map here just how scarred it is. But in this one we managed to find the arrhythmia going through this portion of healthy tissue, and then just extending the scar line through that was enough to help. Here we have circling around a very small island of healthy tissue. But you look at that voltage map and you know that they're going to be back. And so I do tell them all to expect this. Just got a couple of propagation maps here to show again from these people, just to illustrate how slow and how widespread things can be. So on the left we have the first map, and you can have a feel that everything is circling around here as a critical area of conduction. And so we ablated through here with termination of this tachycardia. After that, we were into tachycardia 2. And so it's just understanding that if you start with one line, you're very likely to get a second tachycardia when you pace, and that you have to think about how you're going to then deal with that tachycardia without completely isolating the atrium and the ventricle from the sinus node, which can be difficult depending on how many lines you may need to draw for the tachycardias. Apologies, this video is not playing, but I think probably one of the things that from a EP perspective that we can do better as a team here is utilising our structural colleagues in complex congenital heart disease. So similarly, I had another one with a complex intra-arterial conduit and recurrent arrhythmias, and I needed to get across to the other venous, to the pulmonary venous atrium. And so I've got my intracardiac echo here, the radiofrequency needle, and so I've done my conduit puncture to get across. But then I've asked one of my structural colleagues to help balloon and enlarge this fenestration so that I can then get all my ablation equipment across. And I think doing some of these things as joint procedures can be very helpful and can help you in some really difficult access situations. So I thought the things I found most useful for these is the RF needle has really helped me in some of the most difficult punctures. I think the development of ripple and vector mapping, especially in identifying critical slow isthmus zones, can be very helpful. Personally, I'm a big fan of the vector mapping in precision and ripple mapping from Carto. And I think these have helped when you've got really densely scarred atrium with lots of areas of slow conduction. Trying to identify what is the critical isthmus can be very useful. Accepting recurrences and the fact that multiple atrial tachycardias will occur on the day is important. And so I think you just need to prepare yourself for that as the electrophysiologist and counsel the patient to that fact. I think what's, in very well-resourced healthcare settings, becoming more of a thing is robotic navigation. And robotic navigation with integrated MRI. Certainly some centres are moving to largely, and I think especially in these Fontans and other really complex structural groups, will be a real boon to improving your outcomes on the day. How long it will be before more of us have access to this, I don't know, but I can really see that helping to develop things long term. So thanks for that. So I think if you look at this graph here, if you have an AP Fontan, your arrhythmia burden is essentially 100% 25 years after your operation. I think, if you look at certainly some of these graphs, in the red here is an intracardiac lateral tunnel, talking nearly 50% by the time you're an adult. The more modern ones, less, probably talking about and yeah, it's hard to deal with in the area you want to play.
Nowadays, they usually do the extracardiac shunt, or they didn't use the old techniques.
Sorry, I missed that.
I mean that the surgical procedure itself is shifted to the extracardiac.
Yeah.
Didn't use the old techniques anymore.
No, we moved to the extracardiac probably about 15, 20 years ago.
So the incidence is now is not seen as frequent as before.
No, certainly my workload from a Fontan perspective is largely the AP group and a few of the older lateral tunnels.
I'm asking this because if we could expect the circuit of the tachycardia VT and Fontan around the scar or so on, why the surgeon, or is it possible for the surgeon to do prophylactic line by RF ablation following the surgery, connecting this scar with any of the barriers, anatomical barriers, to prevent the possible arrhythmias in the future?
So certainly some of the surgeons can. I think one of the issues is that if you're having your Fontan completed, you're very likely, certainly in the UK, to be less than 5 years old. So whether you want to be doing an extensive, maze type procedure in a 4 or 5 year old is up for debate. Certainly if you do, you're going to increase the risk that they will need pacing, which will increase the chance that their by the time they get to me in adult, their epicardial leads will have failed. So I think it is a difficult balance to make that decision on someone so young. I think the other thing is these surgeons are very poor at being able to do a durable lesion set. They may well ablate, but they have no way of proving block. They won't test for inducibility or non-inducibility. And I guess to be fair to them, if they have a very sick, young child that they're completing the Fontan on, they probably want their operation to be as quick as possible and probably won't be interested in helping us much from the EP perspective.
Okay, thank you very much. I ask if anyone have any further question.
I have a question to Dr. Ashrafi. Thank you very much for very in-depth lecture. I know that complex congenital cases, ablation of such cases is challenging. What is your advice for us? We do cases, yes, but you said in your lecture that we should get our structural, our pediatric group who are experienced in catheterization of such cases with us as a team to start with?
Yeah, well, I think it depends where you are and what your expertise is and who you have available. If you want to do a complex conduit puncture, and I guess if you don't have the experience and they do, getting them to help you can be invaluable. Certainly, I've asked for help from them for quite a few cases, especially in pacing, when I've, done a conduit puncture and I've asked them to snare the needle so I can pull through from the top.
Yeah.
I think it can be very useful sometimes. I guess the other thing they're quite good with is intracardiac echo, which can sometimes help you. And I think in these most complex cases, sometimes having a second pair of hands or someone to help with the bits that maybe you're not as good at, can be invaluable.